Hey everyone, welcome to this high-yield explainer. If you're an MBBS student prepping for your microbiology exams, you're in the exact right place. I know how overwhelming parasitic infections of the central nervous system can be, but today we're going to break down Naegleria and Acanthamoeba into a highly structured, super easy-to-recall format.
Here's our game plan for today. We're going to hit the basics, walk through pathogenesis and clinical features, tackle the lab diagnosis, look at treatment and prevention, and then wrap it all up with some quick revision points to lock it all in.
All right, Section 1, Free Living Amoeba Basics. Let's get right to the foundational etiologies of these opportunistic neuroparasites.
So what exactly does free living even mean here? Well, it means these are tiny protozoa just hanging out in the environment, mostly in soil and water. They absolutely do not need a human host to survive. But when they do accidentally find their way into a human body, and specifically the central nervous system, they cause absolute devastation.
Examiners absolutely love testing the differences between our two main culprits here. So let's look at them side by side. Naegleria fowleri causes primary amoebic Meningoencephalitis, or PAM. Acanthamoeba species cause Granulomatous amoebic encephalitis, or GAE. To lock this into your brain right now, use this mnemonic. N for nasal swimmer, that gives you Naegleria's route and typical host. And A for airborne AIDS opportunistic, that gives you Acanthamoeba's aerosol route and its typical immunocompromised patient.
Now this is a super common spotter question, so pay close attention to the microscopic differences here. On the left, notice Naegleria's amoeboid form, with those rounded lobular pseudopodia. We call those lobopodia. And it has this crazy ability to actually transform into a flagellated form. Now compare that to Acanthamoeba on the right. Totally different. It has these sharp spine-like projections called acanthopodia. And check out its cyst stage. It has this really distinct, wrinkled, double-layered cyst wall, which is completely different from Naegleria's smooth cyst.
Okay, Section 2, Pathogenesis, the brain invasion. How do these things actually breach the heavily guarded central nervous system?
As you can see here, Naegleria's entire life cycle revolves around water. Human infection usually happens when these free-living amoeboid trophozoites are hanging out in warm, fresh water. Think lakes or maybe a poorly chlorinated swimming pool. If a person is swimming or diving, that contaminated water gets forcefully inhaled right up into the nasal cavity. So once it's up the nose, how on earth does it reach the brain? You're going to want to memorize the NOCB steps for your exam. NOCB. First, the amoeboid form invades the nasal mucosa. Then, it travels directly up the olfactory nerve. It crosses that porous cribriform clade of the skull, and bam, it immediately causes severe, direct brain necrosis. It's literally digesting the brain tissue using specialized food cups. It's as terrifying as it sounds. Now, in stark contrast, Acanthamoeba takes a completely different route to the brain. Instead of using a direct neural superhighway like Naegleria, it relies on sneaking through alternative doors and taking a much more systemic, scenic route. To differentiate it, remember the ALHC invasion pathway. ALHC. It enters the body via aerosols or broken skin. Then, it sets up a primary infection site in the lungs or sinuses. From there, it uses hematogenous or blood-borne spread to eventually reach the brain, where it finally forms subacute CNS granulomas.
Moving right along to Section 3, Clinical Features, PAM versus GAE. Let's see how that pathogenesis actually looks on the ward when you're treating patients.
For Naegleria's disease, PAM, I want you to think of the word FAST. F-A-S-T. The clinical course has a fulminant acute onset. Patients often show up with anosmia, which is changes in taste and smell. That is a massive clinical clue pointing directly to that olfactory nerve damage we just talked about. They'll also have a stiff neck and positive meningeal signs. And tragically, the outcome is terminal within just 7 to 14 days.
This comparison right here is pure exam gold because it sets up the perfect differential diagnosis. You really have to contrast the acute 1 to 14-day onset seen in healthy children and swimmers with PAM against the slow, insidious, weeks to months onset of GAE. GAE almost exclusively targets immunocompromised patients, like folks with HIV. So remember, PAM is a fulminant suppurative infection, while GAE is a subacute granulomatous disease.
And here is the most sobering fact for any future clinician. PAM has a shocking 98% mortality rate. It is quite literally one of the most lethal infections known to modern medicine.
Because of that astronomical mortality rate, rapid detection is absolutely everything. Section 4, Lab Diagnosis. How do we quickly confirm this under the microscope?
Your primary diagnostic tool is the cerebrospinal fluid. Let's compare the CSF findings closely. Naegleria mimics acute bacterial meningitis. The CSF is going to be thick and purulent, with a massive neutrophil count, often over 20,000. But crucially, you will see absolutely no cysts in the CSF with Naegleria. Acanthamoeba, on the other hand, shows lymphocytosis, and in severe AIDS patients, you might see no cells at all. But unlike Naegleria, you might occasionally spot Acanthamoeba cysts in the fluid.
Burn this visual right into your memory for those spotter exams. When you do a biopsy or look at an H&E stain, Naegleria trophozoites look exactly like this. They've got this granular sky blue cytoplasm and a super distinct pink nucleus. Notice that large, prominent central karyosome with basically no peripheral chromatin. That is your dead giveaway.
When it comes to lab techniques specific to Naegleria, just remember the mnemonic WET, W-E-T. First, do a wet mount immediately to check for those motile, lobular trophozoites. And whatever you do, do not refrigerate the sample. Second, culture it on a non-nutrient auger seeded with an E. coli lawn. The amoeba will actually eat the bacteria and leave these visible track marks called the trail sign. Finally, T is for the transformation or enflagellation test. If you put the amoebae in distilled water, they will literally transform right into their flagellated form.
All right, Section 5, Treatment and Prevention Plan. Given those crazy mortality rates we talked about, the options here are unfortunately pretty limited. For the Naegleria treatment protocol, recall the acronym AMP. Amphotericin B is your absolute first-line drug. It's one of the very few medications with any documented success against Naegleria. Miltefosine and rampicin are used as alternatives in combination therapies, but honestly, prevention is the most powerful tool here. You've got to advise patients to avoid getting warm, fresh water up their noses. Using nose clips when swimming in lakes is a simple, literal lifesaver. Conversely, there is no truly effective, standardized treatment for Acanthamoeba GAE. Management is mostly supportive care combined with various antifungals like miconazole and fluconazole. Because it's so incredibly hard to treat, prevention is paramount, especially proper hygiene for contact lens wearers to prevent keratitis, and avoiding aerosol exposure if a patient is immunocompromised. We have covered a ton of ground today, so let's lock all of this in with Section 6 quick revision points. I highly recommend taking a mental snapshot of this master cheat sheet right now. It condenses everything we just covered into the exact differential framework your examiners are hunting for. Naegleria causes PAM in healthy swimmers via the olfactory nerve, and you identify it by labopodia. Acanthamoeba causes GAE in the immunocompromised via hematogenous spread, and you spot it by its spiny acanthopodia and that weird wrinkled cyst. Before we wrap up, I'm going to leave you with a classic board question to test your recall. A healthy 15-year-old presents with fulminant Meningoencephalitis 3 days after swimming in a warm lake. What specific amoebic form will you look for in the purulent CSF? Think back to our discussion on morphological clues and lab findings. Can you identify the exact stage of the parasite hiding in that spinal fluid? Take a second to review these key facts if you need to. Good luck with your exams, and keep studying smart.